Alcohol use disorder in India extends beyond an individual and significantly affects the family functioning, especially the spouses who undergo severe physical as well as emotional strain out of their caregiving experience, and this often remains under-recognized in the clinical practice. Living with a spouse affected by AUD exposes wives to persistent stress related to conflict, financial instability, uncertainty. And caregiving in this context represents prolonged emotional exposure rather than episodic tasks. And over time, this sustained stress contributes to emotional exhaustion, physical strain, and reduced quality of life. And the socio-cultural stigma often leads to internalization of distress and limited help-seeking behavior. There have been many studies which tell us that there is significant amount of distress among the caregivers of individuals, but what is unclear is regarding the interaction between the burden, coping, and the quality of life. And what remains underexplored is the socio-demographic factors, the caregiver-focused outcomes, and the Gujarat prohibition context. And our study kind of aims to address some of these issues in it. So, it was conducted with aims and objective to study the association between caregiver burden with coping strategies and quality of life among the wives of individuals with alcohol use disorder, and to determine the correlation between severity of alcohol use with caregiver burden, quality of life, and the coping strategies. It was a cross-sectional observational study which was conducted at Parul Sevashram Hospital, where around 200 wives of individuals with AUD participated, where the following assessment tools were applied on them, which consisted of basic demographic details, burden assessment schedule, Orford coping questionnaire, and the WHO quality of life scale, following which data analysis was done using the SPSS 25th version, and tests like pair t-tests, ANOVA, and Spearman correlation were used. Results. This table shows the basic demographic details of the participants, where we had around 200 participants, and we can see that most of the participants belong to middle age, were homemaker, residing in rural areas, and belonging to the joint family types. This graph shows that the caregiver burden was moderate to severe, and it was uniformly distributed across all the domains that were well-being, marital, social, severity, and the appreciation. This graph shows the coping strategies that were adopted by the wives, where we can see that the engaged coping was prominently used, indicating active attempts to manage and respond to the alcohol-related stress, which was followed by tolerant and then the withdrawal type of coping. This graph shows the deficit from the healthy quality of life, where we can see that almost the quality of life was compromised across all the domains, with psychological well-being being the most impacted. This is one of the most important graphs where we can see the direction and the strengths of the correlation between the burden, AUD severity, the coping strategies, and the quality of life, where we can see that as the burden increased, there was an increase in the alcohol use severity, as well as there was an increase in the tolerant coping, while it was negatively correlated with the quality of life. In contrast, engaged coping was associated with lower burden, better quality of life, but as the alcohol use severity increased, the use of engaged coping reduced. In our regression analysis, we found that tolerant inactive coping was the strongest predictor for the caregiver burden. In our mediation analysis, we found that as the alcohol use severity increased, there was an increase in the caregiver burden, but it was significantly mediated by tolerant inactive coping, which was used by the wives. The effect size showed that there was a relation between the education and the burden, where we can see that education had an influence on the burden, while the family type and the residence had an influence on the type of coping that was used by the wives. Discussion. We found that there was substantial caregiver burden along with marked impairment in the quality of life. The findings reinforce the understanding of AUD as a condition that affects the entire family rather than the individual alone. We found that there was moderate to severe caregiver burden, which might be due to the chronic and the cumulative strain, and it tells us that stress permeates in multiple aspects of daily life. In terms of Indian socio-cultural context, the wives are expected to maintain family stability, tolerate adversity, and prioritize marital continuity, leading to the silent endurance of distress. Along with it, the limited appreciation for caregiving efforts with marital conflict and stigma further intensify the emotional and the psychological strain. Coping strategies did play a central role in shaping the caregiver burden, where the wives who relied on tolerant inactive coping experienced higher levels of burden, suggesting that passive endurance and emotional suppression, though culturally encouraged, gradually intensify the psychological strain. While in contrast, engaged coping was associated with relatively better quality of life, indicating that the problem focused approach and the emotional expression may offer partial psychological protection, and this was aligned with the stress strain coping support framework. Quality of life was impaired across all the domain, with psychological well-being being the most affected. It could be due to the sustained stress, uncertainty, and the repeated relapse cycle that erode the emotional resilience. While social functioning was relatively preserved, it could reflect the role obligation and social adjustment rather than the genuine well-being. Environmental limitations such as reduced autonomy and restricted access to care further compounded the distress and delayed help-seeking behavior. Caregiving experience was strongly shaped by the social and the contextual factors, where lower education was associated with greater burden, possibly due to limited access to information and support. Rural residence was linked with tolerant coping, reflecting stigma and restricted help-seeking opportunities. Joint family setting did provide some buffering through shared responsibility and emotional support, while employment outside the home and the alcohol prohibition in Gujarat intensified the secrecy and the delayed help-seeking behavior, thus further increasing the caregiver isolation and stress. So what can be done for this? How can we move from burden to action? We have proposed a three-stage model for that, where stage 1 consists of screen and identify to look beyond the patient and assess the caregiver also. Stage 2 is to challenge the silent endurance. That is, we need to tell the patient that endurance is not equivalent to resilience. We need to move forward towards that, and it only leads to exhaustion and nothing else. Stage 3 is transform, to focus on the spouse inclusive care, to shift towards the engaged coping, and promote the problem focused skills. The strengths of my study were that it was a large sample size using standardized validated tool and an integrated assessment of caregiver burden, coping strategies, and the quality of life. There were some limitations, which were that it was a cross-sectional design, limiting the causal reference, reliance on self-reported measures, and hospital-based sample may not capture the most distressed caregivers. What can be done in the future is that some longitudinal studies to track changes in the burden and coping over time, development of spouse-inclusive, family-centered intervention, and routine caregiver assessment and support within the de-addiction services. So to conclude, wives of individuals with alcohol use experience substantial caregiver burden and impaired quality of life, which are shaped by coping styles and socio-cultural context in addition to alcohol severity. These findings reinforce alcohol use disorder as a family condition, and these women function as a hidden patients within our treatment. Our findings highlight the urgent need to look beyond the patient, to routinely screen the spouses for caregiver burden, and to shift the intervention towards family inclusive, coping focused care. If we fail to support the caregivers, we risk undermining the recovery itself. Thank you so much.